all the way down, all the way down, all the way down. Okay, so. I don't have a high-pitched voice all day today. Okay, so I get them locked in between my knees. Okay, I'm gonna get right on the base of the sacrum. Okay, it's like P to A on the sacrum. Get them here, and then it's you're rotating. You're just doing kind of a straight backward thrust. It's all in the glutes and in the hamstrings. I don't like that way because it's very awkward. But if I don't have an extra set of hands, okay, and extra set of hands can be a tech. The tech's not doing the manipulation; they're helping me stabilize. So a lot of times I'll just grab a tech and say, "Hey, I just need you to put your hands right there and hold that." But Charlie's gonna be my other way. Okay, here, and I'm still gonna internally rotate them with this, and that's a straight caudal distraction.
Now stop doing application grab.
I'm gonna stabilize. So 90% of the time, actually probably 95% of the time. You're still continent, I hope so.
He's too much taller.
My go-to is that supine, straight caudal traction because I can get the patient in supine, I can get them to relax, I can see their reaction. I don't like many techniques where I can't see the patient's facial reaction, see their body language. See what their pain reaction is to that technique. If they're in prone or my back's turned to them, I can't see that. So.
If the patient's like heavy, are you able to still get a pretty good quick thrust with them in the supine?
Yeah. So can I borrow your leg for a second? I'm not saying that. I'm saying. What if there's a challenge of someone that is a little bit more muscular developed in their leg? And it, yeah, I'm just gonna shut up. This is like home. I'm digging myself even deeper by the minute. So, okay. So if that's the case, okay, maybe I don't have the arm strength to get him up into flexion and abduction and into a rotation. So there's nothing wrong with that. I can come in. I can elevate the table a little bit more, and I can modify the technique with football. Line. Okay, so, and this is real. I mean, you're going to see patients all the time that were former O linemen, D linemen, they've stayed muscularly developed through their upper and lower quadrant, and you might not be able to lift that leg up. And Cass sees that a lot with the residents at TCU. You get a 110-pound female, and then you get a 300-pound lineman. It's really hard to put them in position. Just barely lift their leg, get them in a position where you can just traction them slightly, and I can still do the same technique.
For patients that have like instability in their knees?
Okay, you can do a variation. Okay, I can get up above the knee. Okay, I can still internally rotate them. So if they have some sort of ACL, PCL deficiency you're worried about manipulating through the knee, a good technique shouldn't put that much traction through the knee to where the cruciates would be affected, but it is a good consideration. So just go above the knee. Same thing, if it's still someone that's got really developed lower quadrant, you're not as developed in the upper quadrant, just getting right here, hugging his leg as much as I can, and then just traction him that way. So it's not from my upper body. Okay, I use my lower body a lot. So I drop back. So I'm here, and then so you can do all upper body. You're going to fatigue pretty quickly. I'm already sweating. But if I use my body to my advantage, all I have to do is drop my butt back, and gravity helps me, and I'm using more momentum to do the manipulation instead of all upper body muscle activity.
You brought it into like internal rotation, and you said you brought it back up.
Flexion and abduction. Kind of like that open pack position of the hip, but I'm fully locking out the hip so that way I'm not going to tweak it. That way I get to the inside. You will usually feel a clunk, not usually a cavitation with this. And it'll usually be yes on what they feel, and they usually report they feel like something moved. But you should feel that femoral head pull that ilium down. There should be I don't even know what you call it, palpable clunk.
Yeah, I feel like it's
Yeah. Questions about either one of those?